Now, we are very, very lucky to have Elise from SANE Australia. And it was mentioned earlier today that this was going to be a presentation that we were going to be provided, and it's understanding how to best respond to the needs of Australians living with personality disorder, and a spotlight on borderline personality disorder, the evidence, the service availability and the treatment experiences. So Elise is an experienced research assistant. She's worked at SANE since December 2017, has a strong background in public health research and has more recently focused on mental health research in the Australian context. And Elise is also a provisional psychologist with experience in cognitive behavioural therapy, dialectical behavioural therapy, and her research and professional interests include borderline personality disorder, eating disorders, and women's health and youth mental health. Thank you. Can you join with me in welcoming Elise?
Thanks everyone for coming to my presentation. Just a little humble brag that since that biography is written, I have graduated. I'm now an actual psychologist, so so I'm very excited about that. So there's a lot of content that I'm going to try to cover in about 20 to 25 minutes today. This is kind of the BPD specific findings of a large report that was written quite recently. So forgive me if things don't seem very detailed or quite brief. I'm more than happy to answer any questions either after the session today or by email or Twitter. So just let me know if you require any clarification that we can't quite get to today. So just a bit about us to get started. So SANE Australia is a national mental health charity working to support 4 million Australians affected by complex mental illness, including schizophrenia, bipolar disorder, BPD, eating disorders, OCD, PTSD, and severe depression and anxiety. Some of the programs that SANE offers include research, which is where this presentation sits today. We also offer communications through our SANE website and our blog, the SANE Forum, so an online service for peer support, a phone-based helpline, a Stigma Watch program, which looks at stigma in the media, and a peer ambassador program. And I know we have a few peer ambassadors that are here today, so welcome everybody. Background to the project. So in 2017, we started working with the National Mental Health Commission, who identified it would be useful to better understand the needs of Australians living with all forms of personality disorder, including BPD. So the aim of this project was to identify evidence-based approaches to prevention, early intervention, treatment and support for recovery and relapse prevention, and to determine what changes are required to address the poor outcomes for many people who are living with personality disorder in Australia. So we did cover all 10 personality disorders that are recognised by DSM-5. However, I will be talking today about the results that were BPD specific. So 3 components were involved as part of this project. First of all, we had a literature review, which looked at the prevalence of personality disorder in Australia and some of the evidence that was available for different treatment approaches. We conducted an environmental scan, which looked at all the different services that are available in Australia, comparing generalist mental health services as well as specialist services, as well as looking at some of the advocacy, educational, research and training initiatives that are underway. There was a qualitative study, which is probably what I'll focus mostly on for this presentation, in which we conducted in-depth interviews with people living with personality disorder or caring for somebody with personality disorder, and focus groups, which were conducted via the SANE forums. And finally, we put together some recommendations for how we can make a meaningful change for these people's lives. And this was all put together in a report, which I will mention again later. So I'm going to go through the 3 project components. However, I will just briefly touch on component 1, because this is going to be repeating a lot of what I'm sure many of you know, as well as what was covered by Bryn today. So first of all, a note on the prevalence of BPD. So I looked at over 500 studies and in an attempt to find good data for the prevalence of personality disorders, and I only found one nationally representative study. So this was the 1997 National Survey of 10,000 Australians, or the National Survey of Mental Health and Wellbeing. So this used a screening tool called the International Personality Disorder Examination, ICD-10 screener, which is using the ICD-10 criteria for personality disorder, so not DSM, which is kind of the dominant diagnostic criteria that most people use in Australia. So what we found was, according to ICD criteria, and ICD doesn't use borderline as a name, they use emotionally unstable personality disorder. We found that about 1% of Australians are living with BPD. There wasn't a significant difference between males and females in this data. And there are some other studies which do provide some different estimates which are available, but they don't provide nationally representative data, but have found slightly higher estimates in different populations. Oh, that was unnecessary. However, as you might have noticed, this data was from 1997, so it's getting a bit old by now. There was another version of the study conducted in 2007. However, there was a change in methodology in that 10-year period, and they didn't actually look at personality disorders. So we didn't get updated data 10 years ago, like I think many of us would have liked. This study did also involve brief screening only and used outdated criteria. As we know, the ICD-11 is much more recent, and this study used the ICD-10. And estimates do vary by study and vary by location as well. So I guess the take-home message for prevalence is that we don't really have great data about the prevalence of BPD in Australia. We make do with what we have. I won't go into much detail about what we know works for BPD, but the reality is we do know what works. We have good psychotherapies which have demonstrated benefits for BPD. So we know DBT works, we know psychodynamic approaches work, schema therapy, cognitive analytical therapy, and a program called systems training for emotional predictability and problem solving, which is understandably shortened to STEPS. BPD is definitely the most researched of the personality disorders, and the only personality disorder with what's called level 1 evidence, which means that there's been a pretty large amount of research which has been consistent. So we know what works. So what's available? So first of all, when looking at specialist services, so what we consider to be a specialist service is something that provides personality disorder specific services, so it might be branded as a personality disorder service, or treatment programs that are known to be effective for BPD, such as DBT. So what we found was there's quite a few DBT programs that are available. Some of them were, of course, mentioned in the presentation just before this one. Most of these DBT programs work in private inpatient settings. There are some schema therapy clinics available, BPD carer support services such as the Family Connections program, which operates in various locations throughout Australia. There are statewide services in New South Wales and Victoria, so Project AIR and Spectrum. And there are some youth and early intervention services such as Origin Youth Health in Victoria. So that map really, I think, puts into place how sparse the services are. There are quite a few that were available, but they were quite limited to capital cities. And those red dots there, those are hospital-based services, and the blue are community-based services. So most of them were kind of in more inpatient, intensive settings rather than community-based outpatient services. We also had a look at more generalist support too. So we know, of course, many people living with BPD will access services that aren't specialist in nature, and that can be okay. It doesn't necessarily mean that those services are bad or wrong or aren't going to provide adequate support. We know that there are general support services such as carer-specific organisations, and we know that there are financial support services that are available, such as Centrelink. So, like I said before, most specialist services are clustered around capital cities, which means it can be very difficult to access support if you are living in a rural or remote area. Many private hospitals and mental health services run a DBT program, and there does seem to be an overemphasis on DBT, although we know it's not the only evidence-based treatment for BPD, and it's not necessarily more effective than other approaches such as mentalisation-based therapy or schema therapy. There were very few public services that were available which offer specialist treatment, support or intensive services. And something that's come up many times today, and I'm sure is going to keep coming up in the future, is that Medicare rebates of up to 10 sessions are not enough to cover these full programs. So for example, if you're in a DBT program requiring weekly support over a year, individual and group-based services, you're probably going to run out of sessions by March. There are other options like private health insurance, NDIS, Medicare safety net, which might make life a little bit easier for some people, but it's not accessible to everyone. And we know that many people have to kind of creatively work the system in order to get as much funding as they possibly can. There has also been a movement of fundings to PHNs, primary health networks, with the expectation that PHNs can provide some gap-filling services, but we know anecdotally that this hasn't always been successful. So now moving on to the qualitative study. So this was a study that we did which was a kind of a novel component. So we conducted 12 in-depth interviews with people living with BPD, as well as carers, families and other support persons. So we recruited people through social media. We conducted an online screening survey first, so we got people to fill out a survey rather than just kind of giving a spot to everybody who requested it, so we could try to get as much diversity within that experience as possible. Although our study was looking at all personality disorders, everybody we spoke to in the in-depth interviews had a diagnosis of BPD or BPD traits. And this was, as we all know, BPD is the most diagnosed of the personality disorders and most recognised. We also conducted 2 online focus groups, so one focused on people with lived experience and one focused on carers. So just a quick note on the online focus groups. So these were conducted by SANE forums. So the forums are an online peer support service. One is designed for people with lived experience, one is designed for carers, families and other support persons. And they provide peer support, information, access and advice for people with BPD and other complex mental illnesses. So these ran, they were online, so it was kind of a back and forth Q&A, but it was all text driven. Of the people we interviewed, 7 of them reported having lived experience of BPD, 3 reported being a carer, a family member or another support person, and 2 identified with both roles. All those names there are pseudonyms, so we're not identifying people here. We also had 12 people who participated in the 2 focus groups, so 10 with lived experience and 2 people in the carers group. The carers group, unfortunately, is a much smaller community than the lived experience group, so we were only able to get 2 people for that interview. So like I said, everyone, or mostly everybody, had BPD. There was also a lot of other diagnoses that people reported. So for example, other personality disorders like schizoid personality disorder or obsessive compulsive, or other diagnoses including depression, anxiety, psychosis, complex PTSD, eating disorders and substance use. So I conducted a thematic analysis on this data, which was done using a program called NVivo. So what this involved was reading and rereading transcripts, listening to audio files and kind of grouping everything together into some themes. So I'm going to go through these 6 themes, but I do want to note that we did have an overarching theme as well, which was stigma and discrimination. I'm not going to go into this specifically, but keep this in mind as I go through the different themes on how this impacts people's experiences. So first of all was identity and discovery. So participants described their experience with BPD as being a journey that was characterised by fighting for themselves, fighting for other people, and personal growth. This started as people first tried to seek a diagnosis. So for example, this was described as being confusing, there being a lot of misinformation around this time, and often taking a long time to reach a diagnosis. For many people, getting a diagnosis was a relief. However, for others, this was quite upsetting, particularly those who had heard a lot of stigmatising remarks or names about people with borderline personality disorder. Most did describe eventually accepting and sometimes identifying with a diagnosis. Self-discovery and acceptance typically continued throughout treatment, as many people became researchers, as they had to search for treatment options themselves, or advocates, as they advocated for themselves or for other people. Participants described the challenges of learning their rights throughout treatment, trying to navigate the system, researching different options as they navigated confusing models of service. There was a sub-theme of burden that came through this. So many people felt that the onus had been on them to provide for themselves, to advocate for themselves, and they wished that this hadn't been the case. So for example, one of our participants, who I've called Maggie, said, "I was struggling. I guess it's all a learning journey, but it would have been helpful if for me I'd had more access to stuff off the bat than having to search for it myself and figure it out myself." The second theme I've called miscommunication. So participants emphasised the importance of clear, honest and sensitive communication throughout their treatment. So for many people, communication was a real issue. This first emerged as mental health professionals were reluctant to diagnose BPD. For many people, getting an accurate assessment and diagnosis took years. Without a diagnosis, people were unable to access evidence-based therapies that they felt they needed. Some participants reported that sometimes their diagnosis was not clearly communicated to them. So, for example, I had a participant that saw on a report, a discharge report, the words narcissistic traits, rather than having that communicated and explained what that meant. This was described as being quite a devastating thing to see. Some participants also described a lack of explanation regarding treatment decisions, so felt that they weren't adequately involved in planning for their treatment. This was particularly the case with carers who felt that they didn't receive enough information to support them and feeling excluded from treatment processes. So, for example, one of the carers said, "No one bothered to ask what I thought. She told them what they wanted to hear, so she'll be discharged, and she was after regulatory observation period, so I had to take her home fearing for her safety, and there was nothing I could do about it." So this was after his wife had attempted suicide. So many people felt that there was a lack of understanding of BPD from family, peers, and in particular health professionals in the general community. They felt that there was a lack of visibility of BPD in the public sphere, and this had a flow-on effect, so fostering misinformation, stereotypes, and stigma. This impacted how far people were willing to disclose their diagnosis, who they were willing to talk to, and in some cases, who they were willing to talk to professionally. So, for example, one participant began withholding information about her diagnosis as she was trying to get into new services. So she'd experienced, when telling people she had BPD in the past, she felt people assumed she was difficult to work with. She also downplayed her experiences of self-harm and suicidal ideation out of fear that that would limit her options accessing services. Complexities of care was a particularly large and complex theme. And many of these have come up today in the conference. So every single participant I spoke to identified challenges when seeking support and treatment for BPD. This did range a lot from person to person, but very few experienced what I call a linear recovery journey. There was a general perception that many participants had experienced or were at risk of falling through service gaps. They felt that there weren't enough services available, particularly in rural areas. Many noted that available services typically had long waiting lists, for example, up to 2 years, particularly in the public system. They also noted there were a lack of specialist resources, and many could only access more general resources. This was perceived to be better than nothing, but they criticised the lack of what they perceived to be a lack of personality disorder training, empathy and understanding by some clinicians in generalist services. Some people reported clinicians behaving in ways that could be deemed unethical or unprofessional. So, for example, I had a participant who reported that her first psychologist yelled at her during a session. Someone reported confidentiality violations in a hospital where there were rumours spread about her daughter, which got back to her. Another participant described a doctor who asked her if she was stupid after she was hospitalised due to an overdose. At its most extreme, these treatment challenges were described as traumatic or re-traumatising. There were some individual factors as well that added complexities to this. So many participants said that the nature of BPD did make it sometimes difficult for them to access treatment or to act in a manner with treatment that they felt made it easy for the clinician as well. So, for example, black and white thinking, difficulty handling conflict, or impulsivity when it came to making decisions about treatment. There were also barriers to completing treatment, so as well as finances, things like having intense emotions or the time commitment that was required to complete treatment. It's very difficult to maintain full-time work if you have to access 4 hours or more of therapy every week. There was also an issue in the context of comorbidities. So, for example, one participant was on a waiting list for DBT program and then told that she couldn't access the service as she developed a substance dependence in the meantime. This was devastating. Financial barriers was a key theme as well. So many people reported going into debt or borrowing money from carers, family, or other people. People valued getting some money back from Medicare, but really felt this was just not enough. And there were mixed experiences with regards to Centrelink, NDIS, and other financial supports. So, for example, one of my focus group participants said, "I started seeing a private therapist since my diagnosis late last year. It's very costly, $190 per fortnight. I can get 10 sessions subsidised by Medicare, but it doesn't cover after that. Considering recovery is any time between 1 to 3 years, it doesn't help. The only other option I have is to get admitted into a mental health unit in a public hospital for 2 months to get access to DBT. I'm too scared of the NDIS and how they will treat me, so I haven't tried." Many people did have some positive experiences. So, for example, as Abby said, "My psychologist was fantastic. He just got down on my level. I trusted him, and yeah, if it wasn't for him, I don't think I'd be there." This did often take a lot of time for people to find what works for them. This usually involved some combination of a long-term evidence-based treatment, psychosocial support, and a holistic approach, such as finding things in their life that gave them a sense of pleasure or a sense of mastery. Self-care was also very important, and clinicians were valued if they were validating, non-judgmental, and skillful. However, the future for many people was uncertain. As Lewis said, 15 years and I'm sort of back in the same spot. I don't know, it's very hard for me to say anything positive. Some people were quite cynical about the idea of getting support and reaching a point of recovery in the future. For some people, this was very, very uncertain. For example, at an extreme level, meeting basic survival needs, having a roof over their head, having enough money to pay for food. Some people felt that their treatment had stagnated, particularly those that had been engaged in services for a long time with little perceived progress. And finally, although some points of carers did come through the other themes, I wanted to note that carers did report additional challenges. As we know, caring can be very stressful and there's a lot of worry associated with caregiving. Some carers felt that there's a lack of carer resources available, particularly for those in rural areas. Not all carers were actually actively seeking out carer support or had been informed about options. Carers felt that they were generally undervalued. So as Tess said, if it wasn't in addition to my full-time job, spending hours and hours supporting my daughter, what would be the cost to society? There's public statements about how important carers are, but they really are undervalued. So I'm going to very briefly mention what some of the next steps are and the recommendations are for this project. So I'm not going to say a lot, which is rocket science, what we don't already know. We need a better understanding of the prevalence of BPD, some updated numbers, so we have a better sense of what the issue is, who's experiencing BPD. We need improved access to treatments and early intervention, so better training, better uptake of the well-written practice guidelines that we have available, and ideally systematic redesign to reduce the financial burden and access for people who can't afford it or people in rural areas. We need a reduction in stigma. We need better support for family and friends. So, as part of this project, we did write quite a lengthy report. This report is going to be published quite soon. We're aiming for BPD Awareness Week, so the first week of October. We're also going to provide some plain language summaries so that people don't have to read 100 pages to get the main points. We are publishing the qualitative component of the study, so the thematic analysis that's under review in what's the journal? Australian Psychologists at the moment. We're conducting a study of health professionals who work with people living with personality disorders, including BPD, so looking at their experiences, training, therapeutic approaches, and stigma, and any myths. If you are a health professional interested in participating, please let me know. I'd love it if you can be involved. We are also working with primary health networks across Australia, looking at how different PHNs can better meet the needs of people living with BPD. This is really a group effort, this report. So I wish to thank our project advisory committee members. Unfortunately, I can't go through everyone, but we did have a lot of people who really contributed a lot of valuable input into the report. I want to thank the National Health Commission who did commission the report for their financial support. Wish to thank everybody who participated in the study. I'm aware it's quite possible that somebody's in this room who participated. Thank you so much. And we wish to acknowledge other members of the SANE team, the WA Personality Disorder Sub-Network, and everybody with lived experience or caring experience who has been involved with the project in some way. Thank you.